Yes, so we are talking about the retropharyngeal abscess. So this is simply, we have the retropharyngeal space that is usually at the throat. The pharynx, you have the oropharynx, you have the laryngopharynx. So usually at that laryngopharynx. Please, can you all see? What is this?
Yes, Doc. Yes, Doc.
What is this? Okay. Yeah, so I was saying, so we have the laryngopharynx, we have the oropharynx, we have the nasopharynx. So around the region of the oropharynx and then the laryngopharynx, that is where we usually have the retropharyngeal space. So it's a space behind the pharynx. So when there is a collection of pus in there, that forms a retropharyngeal abscess. So this is usually caused by suppression of retropharyngeal lymph nodes following severe bacterial infection of the nasopharynx, and then suppression of retropharyngeal lymph nodes, usually following severe bacterial infection of the nasopharynx. There could also be from extrapulmonary tuberculosis. Remember, tuberculosis can either be pulmonary or the extrapulmonary. So extrapulmonary, that is the type of tuberculosis which is outside the lungs. So there could be a group A hemolytic strep or Staph aureus causing that, or some foreign body hidden there. So they also clinically present with fever, sore throats, difficulty in swallowing, hyperextension of the neck, livid, and then the noisy. Yeah, so the signs are respiratory distress, stridor. Can you find out the difference between stridor and rhonchi? Stridor and rhonchi. Yes, in your own studies, difference between stridor and rhonchi. Very, very important. Or wheezing and stridor. Yes, I think let's do wheezing and stridor. Yes, wheezing and stridor. Difference between wheezing and then stridor. Retropharyngeal abscess could also present with a bulge in the posterior pharyngeal wall, a reddened throat, large and inflamed tonsils. Investigations, there could be some lateral soft tissue seen following a soft X-ray. So following the X-ray of the neck, and also for the extra pulmonary tuberculosis causing this retropharyngeal abscess, a chest X-ray can also detect possible lung infiltration. Treatment: deal with the pains, the fever, you can do analgesics, antibiotics, and then we can also surgically incise and drain the pus through the oral cavity when the need be. But usually the IV antibiotics and the painkillers are enough to deal with retropharyngeal abscess. There could also be certain cancer of the pharynx, benign tumors, malignant tumors. These are, just for your readings. Yes, and now we come to the larynx. So the larynx, also known as the voice box, which is like a tube-shaped organ located in the anterior part of the neck, usually between the pharynx and the trachea. So between the pharynx and the trachea, that is the larynx. So we have the nasal cavity, we have the pharynx, we have the larynx. Before we go to the trachea, we have the bronchus, the bronchiole, the alveoli, forming the typical respiratory tree. So the typical respiratory tree, we have the pharynx, the larynx, the trachea, the bronchus, the bronchi for both the bronchiole and the alveoli. So the larynx is usually, which is known as the voice box, is a component of the respiratory tract located in the anterior neck. And the main function is for phonation. That is for, now I'm using my larynx, my voice box, phonation. Cough reflex, cough, swallowing. protection of the lower respiratory tract, and also for breathing. Because once the larynx is occluded, air will not be able to move from the nostrils into the lungs. And the laryngeal framework is about 5 centimeters long and is made up of 3 paired cartilages. So kindly take note of these, the 3 paired cartilages and then the 3 unpaired cartilages. So the 3 paired cartilages are the arytenoids, the corniculate, and then the craniform muscles. So these constitute the 3 paired cartilages of the laryngeal framework. And then the unpaired cartilages are the epiglottis, the cricoid, and the thyroid cartilages. So the arytenoid, corniculate, and then the craniform cartilages, the 3 paired ones. So it means that we have 2 each of the arytenoids, corniculate, and the craniform. And then the unpaired ones, the epiglottis, that usually closes the respiratory tree to prevent aspiration of food. And then we also have the cricoid and the thyroid. And then the larynx. There are certain intrinsic muscles which are usually used for phonation, that is by adjusting the position and the tension in the vocal folds. And then we also have the certain extrinsic muscles which are used for elevation, depression, and the stabilization at the vocal folds. And we have the superior laryngeal nerve and the vagus nerve as the main nerve supply, and the blood supply, usually the superior and inferior laryngeal from the superior and then inferior thyroidal arteries. So these are the pathologies. So all that are just the anatomy, So it's a voice box, the main, which is located in the anterior neck, and it is one of the major components of the respiratory tree. The main function for phonation, cough reflex, swallowing, breathing. And then it's about 5 centimeters long. We have 3 paired cartilages, 3 unpaired cartilages. And also there are certain intrinsic muscles for adjusting the position and tension. And then the extrinsic muscles are usually for elevation, depression, and stabilization at the vocal folds. And the nerve supply, the vagus nerve, the superior laryngeal, the blood supply, usually from superior and inferior thyroidal arteries. So in the case of the pathologies, there could be congenital anomalies. It could be congenital anomalies, and then certain infections of the larynx. So as part of those congenital anomalies, you have the laryngomalacia. That is caused by the neuromuscular incoordination or carcinogenous immaturity. So when one is unable to fully, expand the larynx, inability to do that. So it's usually present at birth, but evident when child is few weeks old. So this is the commonest congenital anomalies of the larynx, laryngomalacia. So the indications for surgery, when there is an obstructive sleep apnea, when it's a cor pulmonale. Yes, please, what is cor pulmonale? Hello, class.
It's an abnormal enlargement of the right side of the heart.
Pardon? Hello.
Hello, Doc.
Hi. Hello, Doc.
Yes,
Hello, Doc.
yes. Yes, please. Yes. What is cor pulmonale?
Right.
Usually, an enlargement of the right side of the heart as a result of maybe a disease in the lungs or an infection in the lungs.
Okay. Yeah, that's fine. I think it makes sense, right?
Yes, sir.
Oh, I think it makes sense. Oh.
Yes, Doc, it makes sense.
Yes, Doc.
Oh, okay. Yeah. So the laryngomalacia, that is, when these larynx around the the larynx, also known as the voice box, when becomes very weak, unable to coordinate, or the cartilage as a result of an immature cartilage. Remember, we have the 3-paired and then the 3 unpaired cartilages. When they are very, very weak and soft, like usually falling over, the voice box, that causes this. That is what laryngomalacia is. Very, very weakened, muscles. And investigation is by laryngoscopy. It can sometimes resolve after 8 months. But if it doesn't, after the diagnosis has been made, then surgery. And it's caused by a neuromuscular disorder. So that's the commonest. And then we also have the vocal cord paralysis, which is the second commonest. So this can be either unilateral or it could be bilateral. So the bilateral causes certain CNS anomalies, commonly hydrocephalus, and then they will clinically present as severe stridor. Once again, difference between stridor and then wheezing. Stridor and wheezing, stridor and wheezing. The voice may be normal, and then sometimes vocal cord, because the vocal cord are completely paralyzed. So one is unable to depress, to elevate, to soften, to widen. It's like you are unable to literally control or to have absolute, you are not unable to manipulate the whole voice box. So that's where we say that the vocal cord is paralyzed. So sometimes you can do a tracheostomy, because once the paralysis happens, it can even occlude the respiratory tree. So you can do a tracheostomy. And then sometimes there is a spontaneous resolution of this vocal cord paralysis. So the unilateral vocal cord paralysis, remember the whole vocal box thing, the 3 paired and then the 3 unpaired cartilages. The patient usually voice weak, minimal airway obstruction. Diagnosis is laryngoscopy, as I said, usually caused by peripheral injury to the recurrent laryngeal nerve, cardiac or great vessel abnormalities. So the recurrent laryngeal nerve can be injured sometimes during certain surgical procedures, such as thyroidectomy. When we are removing thyroids from the result of conditions like goiter, either solitary, either multinodular. Sometimes if care is not taken because of where the laryngeal nerve passes, don't take care, the surgeons usually service or sometimes injures the recurrent laryngeal nerve. I remember the recurrent laryngeal nerve is one of the major nerve supply to the larynx, to the voice box, and that can cause a complete vocal cord paralysis. And the main management is that we usually manage a private condition causing that. So we can attempt to do a plastic, we can attempt to join or oppose the loose ends of the recurrent laryngeal nerve. We can also usually inject fat, collagen, or Teflon if there is any form of aspiration. All these are managing the vocal cord paralysis. Okay, so the third commonest, sublotic stenosis. So that is when there is a narrowing of all of the glottis. That is the epiglottis, when there is that narrowing. So present when the lumen is less than 3.5 millimeters in a newborn. So they will clinically present in the first few weeks with recurrent croup and stridor. So recurrent croup, we'll know what the croup is. Once again, stridor. So stridor is like a respiratory symptom, just like wheezing. Stridor. So once again, the difference between stridor and wheezing. Kindly take note for me. Investigation, the X-ray will usually show a funnel-shaped opening in the subglottis. And diagnosis, laryngoscopy, self-limiting, tracheostomy, if severe, with dilatation or laryngoplasty. All these things are more or less like surgical stuff. So that's the reason why I'm going pretty fast. So all that you have to know is that we have about 3 common types of congenital anomalies of the larynx. So we have laryngomalacia being the commonest, the vocal cord paralysis, the second commonest, and the subglottic stenosis, that is the third commonest. Yes. Now we have the subglottitis, also known as the laryngotracheal bronchitis. That is when you are having like a whole inflammation of the larynx, the trachea, and the bronchus. So there's like inflammation of the tissues in the subglottic space or the tracheobronchial tree, causing swelling of the mucosal line, and is associated with thick, viscous mucopurulent exudates, which compromises upper airway. So it's basically a viral infection. So croup, also known as a subglottitis or acute laryngotracheal bronchitis, is caused by viral infection. Typically, the parainfluenza 1, 2, TB, as well as the influenza A and B. So common among age group 4 months to 5 years. So between 4 months to 5 years, between 4 months to 5 years, between 4 months and 5 years. That's something that you have to take note. And this usually is preceded by upper respiratory tract infection, and it usually occurs at night. So clinical features: low grade fever, hoarse voice, barking cough, like dog barking cough, and then breathing difficulty, restlessness. Other signs are stridor, respiratory distress, cyanosis, in severe obstruction, and then running throat. But one thing that you have to take note is that they appear less toxic than epiglottitis. Epiglottitis, you know what the epiglottitis is. So we know of the subglottitis, which is viral infection, usually between ages of 4 months to 5 years. 2, 3 influenza and influenza A and B causes this condition. It usually presents with restlessness, difficulty breathing, whatever. We also have investigation, the simple sign or on an antero-posterior X-ray of the neck. So if there is a recurrent, one should always think of a subglottic stenosis as a possible cause. Treatment: you admit all patients except for mild cases. That is based on clinical judgment. You nurse the patient in a humidified environment. Encourage liberal oral fluids. You give IV fluids. You administer humidified oxygen for restlessness and then most distressed children. That is if the saturation is usually less than 92%. You establish airway by intubation or tracheostomy in an extremely severe obstruction. Remember, it's an infection of the larynx, the trachea, and the bronchus all together. So there's a possibility the inflammation can lead to edema or exudates within these structures. That can even collapse the lung. And then we also have pharmacologically, we can do IV steroids to halt the ongoing inflammation. And then we may consider antibiotics for a possible superimposed bacterial infections. And then we also have the acute epiglottitis. So this is like an acute and life-threatening infection in which the epiglottitis and surrounding tissue become acutely inflamed. Like I said, this is more serious than the croup, and it's an acute and life-threatening condition. So it's usually caused by, the reason why it is very severe, the fact that it is bacteria causing this discomfort or causing this condition. It runs an extremely rapid course, usually 4 to 6 hours, and can lead to an immediate respiratory failure and even death. Whilst this is common among 4 months to 5 years, it's like common epiglottitis. Whilst croup is common from 4 months to 5 years, this is common among children between 1 and 4 years. but the incidence has reduced due to the recurrent immunization program. Remember, we immunize against the influenza as well as the pneumonia. That is, we now do the rotavirus, we do the pneumonia, the influenza, and then what have you. They also clinically present with sudden onset of high fever, no preceding common cold. The child prefers to sit up, that's a tripod position. Usually sometimes the leg crossed, drooling of saliva from sore throat, dysphagia, toxic looking child, and the child there may be some form of respiratory distress. Investigation, elevated white blood cell, obviously, with erythrophilia indicating bacterial presence. And then you can also do a blood and pharyngeal cultures right after the intubation, and then can have your lateral neck radiograph. So the treatment, you secure your airway, IV access with hydration, antibiotics, humidified oxygen. You estimate when the leak around the tube occurs and the patient is afebrile. That is when the child is, when the condition is getting better. And then you also watch out for possible meningitis. Thanks be to God. Yes, so we are almost, we are done. We are done for today. But once again, your assignment. For that, I'm going to send the slides to you now. The assignment, you just state some differential diagnosis of hoarseness of voice, stridor, sore throat. Just that. You state 5 each. 5 differential diagnoses for hoarseness, stridor, and sore throat. Just that. And then kindly read on the tracheostomy. You kindly read on the tracheostomy. Yeah, sorry that I rushed through. There isn't been that this kind of conditions, you just have to know it. Most of them are surgical, surgical based, with the exception of the typical infections of the larynx. That is the subglottitis and then the epiglottitis. That's more medically inclined. But the rest of them, the various congenital anomalies of the larynx, the laryngomalacia, the vocal cord paralysis, the sublotic stenosis, all those conditions, they are surgically oriented. So you just know that they exist. And then you just concentrate more on the medical aspects. Yes, so that is all for ENT, at least for now. That is all for ENT.
Wow.
So our next meeting, please, do you have any questions? Any questions?
Oh no.
Sorry, today I really bombarded you guys.
Elijah.
With a lot of things. Yeah, today I'm very sorry. I've really bombarded you guys with a lot of stuff. So I'm sorry.
That's all right. That's all right.
Yes. So what you would have to do now.
Hello, sir.
Yes, please.
Yes, please. This very page you are now. Is the harbors. The harbors. It says harbors 2 passages. The first one says through the esophagus or pharynx, which extend from the basis of the skull to the esophagus. You are mentioning the esophagus again. I don't get it.
Okay. Sorry. I think it should have been just through the pharynx.
Okay.
Through the pharynx. Sorry, yes. It's just through the pharynx, which extends from the base of the skull through the esophagus. So it's rather the pharynx. Sorry.
All right. Thank you.
There are lots of. I will just quickly, edit some of these stuff. We realize that there are some numeral. Then some of the numbering are a bit problematic, and then some of the words are wrongly spelled, and then whatever. So I'm just.
So please, the assignment, when are you supposed to submit it?
So this one, now we are done with ENT, so our next meeting will be face-to-face. So I'll try and then liaise with the class reps while writing your exams?
We're starting
No.
19th,
While you're writing your exams.
19th April, Doc. 19th.
Hey,
Oh, okay.
Yeah, 19th to 31st
Oh,
April.
and I used to understand.
19 to 30.
1st April.
Oh, okay. Okay. So when do you want us to meet face to face? Is it a week before the exams or?
Yes.
Okay,
yes.
so I'll allow the class rep to deal with you guys so that you can just give me the appropriate time and date so that we meet, and then we just go through some of the things that you should be expecting in your exams. I mean, like I said, the exams will just be something very simple. We'd have a question each under ear, throat, and the nose, and then you have a cool 35 MCQs and then 5 true or false questions. And then I'm contemplating on whether to give you 2 questions each under ear, 2 questions each under nose, 2 questions each under throat, so that you select each one of them, or you just get the typical medical style where you just answer everything, just answer all questions. Where you don't have that luxury of choosing, you just answer everything, especially for a clerkship exams. You just answer everything. So we'll see how things go. But just concentrate. You see, the thing is that just concentrate on the simple and common things. Don't stress yourself with a lot of, big things that you discuss. Just concentrate on those simple. You'll be fine. Okay.
Hello, sir.
So,
hello, sir.
yeah. Yes, please.
Yeah, please. The slides you own us. The last slides.
Yeah, I'm going to send all the slides to you right now, right after the class. I'll send everything to you.
Oh, that'll be great.
Yes. I'll send everything to you right now.
Okay.
Yes. Okay. So Charles, see you guys in person, and then do have a wonderful evening. Okay.
All right.
All right. Thank you, sir.
Thank you very much.
Thank you.
Bye.
I don't know how you're doing, sir.